Good morning, good afternoon, and good evening. Welcome, 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 wherever you are around the world, to the World Society of Pediatric Ophthalmology and Strabismus, WSPOS, Season 3, Webinar number 7 on Vernal Keratoconjunctivitis. This is a very exciting day for all of us here, and we're so thrilled that you're joining us. And while we do these webinars, I get signaled to where people are around the world listening to us. And it's really incredible that already we have people logging in from, I'm in North America where it's 6 o'clock in the morning, but we're getting people logging in from all over the world. And I'm already seeing places like Singapore, like Hong Kong, like all over Europe. I'm not even going to start naming the countries yet, but we see France and England and Spain and it's just going to keep going. Welcome to the Middle East that has joined us. I see Lebanon and Israel and Saudi Arabia is here. Welcome to Africa. Nigeria is here. Ghana, there's someone who's joined us. So this is really a worldwide meeting. Brazil, welcome. Argentina, Colombia in the Central America. So already we have a worldwide audience joining us for Vernal Keratoconjunctivitis, and we have a worldwide panel that has joined us as well. That is really phenomenal series of experts that's going to be joining us today. And let me tell you a little bit about who's here, because I think this is extremely exciting. Dominique Bremont-Genac from Paris, who is a double doctor, one of those MD, PhD smart people, and is the head of the department at Necker University Hospital for Sick Children. Everybody here has got a long list of credits and accomplishments and letters after their name. So I'm gonna shorten everything and so you can hear them talk and hear their expertise. But Dominique is one of the world's experts in the external disease of the child. Asim Ali is joining us, who is at Toronto Sick Kids and is the ophthalmologist in chief at Mira Goddard Chair in Vision, blah, blah, blah. And you probably know all about the work that Asim has done. And it's pretty amazing, some of the work that he's done with the cornea and some of the research that he's done. And we'll hear about that today. Merle Fernandez is joining us as well from Hyderabad, where we had one of our world congresses for the World Society of Pediatric Ophthalmology and Strabismus. Merle is a consultant there in cornea and anterior segment, the director of the Reddy Campus, LV Prasad Eye Institute in Hyderabad, another expert. And I am thrilled to have partnering with me today one of just a fabulous pediatric ophthalmologist, Salway Leo, who is an incredible thinker, incredible speaker, and really knows how to identify key points. And I'm just thrilled Salway is joining us from Singapore, where she's a senior consultant. And I will turn the next chunk over to Salway to introduce the rest of the people here.
Hi, it's my honor to introduce my co-moderator, who actually doesn't need any introduction, Dr. David Granite, one of the co-executives of WSPOS from San Diego. And of course, Dr. Ken Nisha, again, another co-executive director of WSPOS from Pittsburgh. Joining us also Dr. Dubey from Delhi. She's the head of the glaucoma service there, and Professor Annegret Darman from London. So we're honored to have them. Just a bit of disclosure, all the moderators and speakers in this session actually have received some form of honorarium from Santen, except for Dr. Dubey and Dr. Fernandez. Some housekeeping rules. So if you have any questions, could you please put them on the YouTube comment section? And if you need any participation certificates, please send an email to admin@wispos.org. If we have missed out any of the questions, please email us, and then we'll have the speakers respond and email back to you. I would also like to put a shout out to our upcoming WSPOS, which we will show some details later. And can I please now invite the first speaker, Dr. Dominique Bremont, to speak on the differential diagnosis in VKC.
Thank you, Silway. Sound is missing.
When you click on share screen, bottom left of that screen, there is a little box that says share sound. You need to tick that box as well.
To present the different. So welcome to this WSPOS webinar on vernal keratoconjunctivitis. It's a pleasure to present the differential diagnosis, because sometimes it's not so easy to understand exactly what is a diagnosis of ocular surface in children. So allergic keratoconjunctivitis alone has been estimated to 6 to 30% of the population. And there is a lot of studies, and a very large study like ISAC study on a lot of children. And there is also conjunctivitis associated with rhinitis. And 30 to 70% of patients get also this allergic rhinitis associated. There is multiple clinical forms from mild to severe, and there is of course seasonal allergic conjunctivitis until vernal and atopic keratoconjunctivitis. So the diagnosis has to be evaluated to understand the prognosis and adapt the treatment. So sometimes really the specific form may be very challenging to be diagnosed. And so what could be VKC, but it's not VKC. So there is other ocular surface disease in children and also other allergic diseases in children. So we know that VKC, it's a rare disease in Europe. And so you have just this evaluation on the map, and you can see that is around 3.2 for 10,000 inhabitants. So it is not so obvious and so common. However, some clinical signs are really very interesting to understand, because they are not really pathognomonic, but they are frequent, like itching, like red eye, and those are really quite constant signs. But there is also a mucus discharge and some poorly specific signs like grittiness or ocular burning. So diagnosis challenges of severe keratoconjunctivitis in children is, of course, vernal keratoconjunctivitis, but also atopic keratoconjunctivitis, flutenular keratoconjunctivitis, infectious and non-immune fibrosis keratoconjunctivitis, which I will not develop at this time because there is a systemic disease in this. So we just go on one case report, which is just a girl of 3.5-year-old, itching, red eye, mucus discharge, and 6 secretions, and treated from since 1 year for VKC. And when she just presented there, she has really a very, very red eye, as you can see here. And there are also mucus discharge, which is abnormal. So you need to make unsampling to go. And what we see here, that there was chlamydia trachomatis infection. So you must be aware of this and just eliminate that. Another case report, because it could be also interesting to see case report that could be challenging. And this 4-year-old girl called itching, red eye, photophobia, mucus discharge. Could be the same case. Ocular surface is sometimes similar, but not the same. When you just look at this, just you can remark this neovascularization in the limbus, which is abnormal. And also, what are you looking for? And so just look at this. This is flictenula, and the flictenula are pathognomonic of ocular rosacea. So this is important also that a non-allergic blepharokeratoconjunctivitis should be eliminated on ocular surface disease in children, and because also the diagnosis is different, and you can see there is sometimes inflammatory abscess, as you can see on the right side on the slide. Another case report for a boy, 8 years old, itching, red eye, blepharitis, eczema, photophobia, mucus discharge. Just look at him. Hyperemia is remarkable, but not so much. There is SPK, there is tarsal, but non-giant papilla. There is transverse dots, you can see here. And just remark also something very specific, which is a Denny Morgan double lead fold. And so this is really important because there is a blepharokeratoconjunctivitis, an allergic one. And this is atopic dermatitis associated with this skin dryness, pseudotosis, and the skin lesions must be just searched for the diagnosis as fissures and atopic eczema in infancy and ongoing eczema. So this is atopic keratoconjunctivitis and not VKC. And so it is very important to make the difference, but because you can see there is differences between those two forms of severe allergic keratoconjunctivitis. But what is very important is the prognosis, because it does not end at adolescence when you compare to VKC. So VKC and ongoing eyelid eczema is atopic keratoconjunctivitis. So this is very important. At the time, we have guidelines ongoing for vernal keratoconjunctivitis in France, and then it will be probably done in ERN. So European guidelines. So just to conclude, there is here a table when you have a keratoconjunctivitis in children, itching, red eye, and so you can go if there is an allergic etiology or non-allergic with giant papilla, with GPC, which is not allergy, with purulent secretion, which could be infection, and when there is skin disease and so you should go to atopic dermatitis or acne rosacea. So take-home message: first, eliminate an infectious keratoconjunctivitis. Two main diagnosis challenges: ocular rosacea, AKC, and early clinical diagnosis make the difference in the follow-up and the prognosis. So recognize the form VKC and AKC. Pediatric, allergic, and skin check are needed. So I just would like to thank you for listening, and my neck care ophthalmology team that are working very hard with me. So I hope you will enjoy this webinar.
Dominique, that was fabulous. Thank you so much for that update for all of us. There's so many questions that I have when I hear you talking. The overlap between all these different diseases, AKC, VKC, even with GPC and irritative conjunctivitis or medicamentosis, the overlap is incredible. And it's hard to expect ophthalmologists struggle with this, but the kids usually start to see a pediatrician first. What can we tip the pediatrician to say, hey, here are some things to the kid who comes in with an allergy and rubbing their eyes. To them, it all looks the same. How do we assist them in separating these out and getting the child to treatment as early as possible?
Well, that's a very good point, because, of course, there is an overlap, and sometimes we need time to make the diagnosis because it's not obvious when you just look at the child just for the first time. So at the onset, usually go to the pediatrician, of course. And what we can say to the pediatrician is probably if there is a recurrence, or if there is no improvement with a local anti-allergic treatment, they need to have an ophthalmologist for examine the patient. And even that, if there is no improvement also, I think we need to have really a pediatric ophthalmologist and or a close surface ophthalmologist, because it's sometimes, as you have seen on the presentation, sometimes very difficult to make the diagnosis in between, because AKC is not so obvious. But if you say the parents, because sometimes there is giant papilla also, and if you say to the parents it will be ending at the adolescence, and it does not, so that's a big problem, because they will not understand why. So that's why it's so important to make the diagnosis and to make it the right one, and to be sure of that. And so for the pediatrician, it's important to have a good advice of the ophthalmologist, and sometimes you need a dermatologist also for skin disease associated, for instance, in AKC.
That brings up a couple of things. Before we go too much further, I wanted to thank our hosts and the people you see above my head. And Todd Pharmaceuticals, thank you. And Santen, thank you for sponsoring this and give us the opportunity to talk about this very important disease. And I'm going to tip my hand early and say I had VKC as a child. I have scars on my cornea from it. My early memories are grabbing my eyes and rubbing them, and I can tell you it affected my childhood. Dominique, the other question I had is, we're ophthalmologists. We're not used to looking at skin. And so are there tips to look at this face and skin? We get the slit lamp and we zoom in on the eye. Should we step back and look at more of the face?
Sure, you must step back, and even before examining the child, you need to step back. And so you have to look. We are used to look at the eyelids, so you can use you can go to the eyelids and just see there is a Denny Morgan fold, for instance, a double one, which is absolutely unusual for children, and also but you can just look also at the canty, at the fissure here on the mouth, and you can go also on the legs or on the arms. So you are not, of course, you're not a dermatologist, but it's so easy to just look at it. And if you see something unusual, you can send them to the dermatologist and they will help for the treatment. And so you will have the diagnosis also. So that's why it's really important to step back and to look the child in the entire body, not completely, but the external, which is easy.
And the last question we have just came in from online in YouTube. The question was, does all VKC end at puberty or adulthood? Does it continue sometimes? Is there such a thing as adult VKC?
Well, I really think it's around 5 to 10% of the VKC that do not end at adolescence, for sure. In between of these, probably some of those cases are AKC and not VKC. But even that, there is just young adults with VKC. It's always very complicated because I don't see that I think in Europe, we have very few cases like this one. But in some other countries, I'm sure there is more. And so if you have a young adult with a VKC, be sure it's not an AKC. That's the first point to me, and try to find out if there is not another ocular surface disease associated, like ocular rosacea.
David, can I just come in on that? So right now there's a group that are describing VKC in young adults. And when you look at their data, it's hard to refute that is a real group. What we don't know is whether that group were a group of VKC adolescents who started at 13 or 14 and were never picked up, and the disease wasn't terrible, and then it suddenly flares in their 20s. Whether that's what's happening or whether it's a disease on its own, that at the moment is a little bit of controversy in this field. And I'd be interested to know what people like Sunita Dubey and Xiao Wei in tropical countries, in tropical areas, what they see. and Merle, of course, as well.
True.
We could get on to the discussion a little bit later because we can go on to the next talk first and I'll come back to all the questions later. So the next talk is by Dr. Asim Asli on the VKC tarsal disease, and then we'll have more discussion later. Please keep the questions on YouTube.
So while we're waiting for the video to start, let me ask that question again. Merle, Xiaowei, Sunita, do you see adult VKC in your countries?
Yeah, so can I come in here? Because we actually published a paper on adult VKC and in Ocular Surface a couple of years ago, where we noticed that there were two subsets of patients that we had. One was a group of patients that had persistence of VKC beyond puberty. So they started at the age of around 4 or 5 and then progressed beyond puberty. And the mean age of that particular group was around 17 or 18 when we looked at them. And then the other group was a set of patients who had de novo VKC, and they didn't have any symptoms of itching in childhood and developed these symptoms later on in life. The subset was a little older in age as compared to the one that presented with the persistent beyond. So we looked at the sex hormone data in that subset of patients, and we are also looking at the fibrosis markers. And there is a stark difference between the two groups, but I can talk about that later. We can proceed with this.
Perfect. Thank you. Thank you so much.
This is Asim Ali. I'll be speaking today about tarsal vernal keratoconjunctivitis. These are my financial disclosures. I'm a consultant for Santen, who produce a form of cyclosporin. This is Asim Ali. I'll be speaking today about tarsal vernal keratoconjunctivitis. These are my financial disclosures. I'm a consultant for Santen, who produce a form of cyclosporin. There are 3 major forms of VKC: tarsal and palpebral, which I'll be focusing on today, which is characterized by large papillae on the tarsal surface of the lid. The limbal form, which includes horner trendus dots and limbal thickening, which can be seen in the top 2 pictures. And in the mixed form, which has elements of both presentations. In all 3 forms, you can have shield ulcers. The prevalence of these different VKC subtypes varies tremendously between studies. The tarsal subtype can be in between 21 and 65% of patients. The mixed subtype can be as common as 81%, and the limbal subtype is around 50% in many studies. These large differences may represent different genetic, hormonal, and environmental differences in patients. I'd like to start out with a case study. It's a 14-year-old girl who presented with a history of, quote, allergic conjunctivitis, as well as systemic atopy. She had been managed with olopatadine and fluorometholone, and she had had persistent mild redness, irritation, and light sensitivity in the left eye for the last year. And as you can see on this image, she has some mild ptosis, as when she's using her brow on the left side, and some mild redness. But when we look closer at her eye, you can see her corneal surface is quite irregular. There's a punctate staining superiorly and centrally. And on everting her lid, you can see these large papillae on the bottom left. She was diagnosed with VKC and was given an injection of supratarsal triamcinolone, and this resolved her symptoms completely. In the long term, she was controlled with topical cyclosporin 1%, and had perennial year-round symptoms of her tarsal VKC. And she had developed a shield ulcer later on when she stopped all her medications for 3 months. Now, she has many of the symptoms of VKC, both pruritus and photophobia. It's also characterized by red eye with discharge, ptosis, and decreased vision. Tarsal VKC is similar to limbal VKC in that all of these symptoms may be present. Blepharospasmatosis can be seen in both forms, although, at least in my observation, it's more common in tarsal VKC. As you can see, this patient of mine has bilateral ptosis and he's using his brows oppressively. When his disease is under control, he's able to open his eyes easily and normally. This underscores the importance of everting lids in these children at every visit. And you can see here a number of patients with large papillae. These can vary significantly in size, and the increase in size is associated usually with chronicity and increased severity of inflammation. The papillae can also be present closer to the lid margin when they become more symptomatic. You can also see this ropey mucoid discharge in many of these patients. VKC is associated with keratopathy. The primary reason for this is an increase in inflammatory mediators in the tear film. These cause decreased adhesion between epithelial cells and greater breakdown of the epithelium, leading to first to punctate keratitis and then confluent loss of epithelium over time. The patterns in limbal VKC include this perilimbal ring, but in the palpebral form, you tend to see staining centrally and in the superior half of the cornea. When you start to get a confluent pattern, this is of concern, at least my experience, and may suggest an imminent shield ulcer. As mentioned, the etiology of the epithelial breakdown is usually primarily related to these inflammatory mediators and their effect on the epithelium. But there is also some mechanical effect of the papillae, which may exacerbate the presentation. Shield ulcers will be discussed further in another talk, but if a shield ulcer leads to Griezmann, consider giving a supratarsal steroid injection at the same time in order to treat these large papillae. In the grading of VKC, the tarsal form is also well described. In the severe and very severe categories, there is a representation for severe papillary reaction, and you can see in the photographs on the right, especially the bottom two, you can see representative images describing this severe form of tarsal VKC. The mainstay of management of tarsal VKC is control of inflammation. This can be done with corticosteroids, but often you require high potency steroids. And depending on the size of the papillae, this topical therapy may take several weeks. And this may be unacceptable given the side effect profile. You can also use a local injection of a depot or non-depot steroids, which can often take a few days to become fully effective. Calcineurin inhibitors are very effective in treating tarsal VKC. There have been multiple studies on both tacrolimus and cyclosporin and their effect in treating tarsal VKC. Again, depending on the clinical presentation, this may take weeks to be effective. In milder cases, these agents may be used alone, but often their role is in prophylaxis and in prevention of cobblestone papillae. Giant papillae, as mentioned, can resolve with topical therapy, but often because of symptoms or because of shield ulcers, it's desirable to address this more quickly. There have been a number of surgical approaches that have been described, including cryotherapy, surgical resection, and the CO2 laser, and adjuvant amniotic membrane and mitomycin have also been used. All of these have been effective in shrinking or removing these papillae, but these approaches will all increase inflammation and scarring. I recommend a local therapy with a supratarsal corticosteroid, and this does not cause any tissue destruction. This is the technique that I use. everting the lid and lifting the lid away from the globe. And then you just inject just above the edge of the tarsus into the potential space. I prefer triamcinolone, although you can have success with a shorter acting steroid as well that's not a depot. Complications of supratarsal steroid injection include increased intraocular pressure and cataract, and depigmentation in dark-skinned individuals, as in the left eye of this young boy here. This is maybe more likely to occur with depot steroid, and is an argument for using a shorter-acting steroid in an individual like this. Also remember that disease can recur. After the steroid wears off, and it's important to restart the steroid-sparing regimen soon after the injection. Thank you.
Wow. That was absolutely fabulous. And as we get our next talk up, that's going to talk about the other aspects of vernal keratoconjunctivitis. And after that, we'll have a wide open discussion. I just want to acknowledge we have more countries coming in, from Venezuela to Ukraine, who our hearts go out to. All over India, every city in India is represented, Sao Paulo and further. This is spectacular because we're hearing experts giving us their the tips and getting quite granular as they drill down on the things that we should know. So the next talk is by Merle Fernandez from LB Prasad, and then we'll have our discussion after that.
So at the outset, I'd like to thank the organizers for giving me this opportunity to present in this webinar. And I'm going to be talking to you today on limbal vernal keratoconjunctivitis and shield ulcer. So we are very familiar with the different classifications of VKC, of which palpable is the most common form, followed by mixed. And isolated limbal VKC is not extremely common. Its incidence ranges from around 12 to 15%. That was noted in a study that was published from the LB Prasad Institute. It's more common in Asians and Blacks, and more prevalent in the tropics as compared to the temperate climes. Clinically, patients would have significant symptoms of itching. They may have ropey discharge. They would have focal areas of limbal thickening. And this may vary from a couple of clock hours to involving the cornea 360 degrees with associated conjunctival congestion. And there may be also Trantas dots, which are these aggregates of eosinophils and degenerated epithelial cells seen as these white dots, either at the limbus or extending onto the cornea. And sometimes we may notice that there is perilimbal pigmentation. In chronic cases, because of inflammation which causes damage to the limbal stem cells, there may be limbal stem cell deficiency, which manifests as this fibrovascular pannus on the cornea associated with an epithelial breakdown. And we notice stipple fluorescein staining when we look at it with a cobalt blue light. So this was a patient who had very severe limbal disease with limbal stem cell deficiency. We'll notice this fibrovascular pannus on the cornea with Trantas dots almost in the paracentral cornea. This was found in both the eyes. But over the course of a couple of months with high dose topical steroids, as well as sodium chromoglycate and immunomodulators, we were able to stabilize the ocular surface. And with the help of a pro-scleral contact lens, the patient's vision improved to around 20/50. But what causes these manifestations? The TGF-alpha and TGF-beta, which are released from the eosinophils, cause angiogenesis, fibrosis, and hyperplasia, giving rise to limbal hyperplasia that we see. Neotaxin attracts WBCs, and this is what results in the Trantas dots. Another manifestation that we may come across is this oval-shaped ulcer, which is noticed usually in the superior part of the cornea. In this particular case, the gentleman was a 23-year-old who had steroid-induced glaucoma, was a known case of VKC, and presented to us with significant pain, redness, photophobia, watering, and a white spot on his eye. And we noticed that there's this lesion, which is an ulcer with a translucent base in the upper 1/3 of the cornea. And when we flipped his lid, we found that he had these giant papillae in the upper tarsal conjunctiva. So this shield ulcer is not very common manifestation of VKC, found in about 0.3 to 11% of cases, usually occurring in the superior 1/3, usually an oval ulcer which is indolent. And though not restricted to the superior cornea, may be found in other parts of the cornea as well. And these are different manifestations that we may come across. Lesions located in the superior part, involving the central as well as the inferior part of the cornea, with a transparent, translucent, or an opaque base. But why do they develop? This is because of the release of eosinophilic cationic protein and major basic protein by the eosinophils, which are highly epitheliotoxic, and this causes the epithelial breakdown. In addition, there's also believed to be a mechanical theory due to the giant papillae rubbing onto the cornea. So patients may manifest initially with these punctate epithelial erosions that will suddenly give rise to coarse keratopathy, macroerosions, and then when these coalesce, it will form an epithelial defect. Cameron, way back in 1998, graded these into 3 types. Grade 1 was an ulcer with a transparent base. Grade 2 had a translucent base, and grade 3 had an opaque base or a plaque. The management of the 3 different grades of shield ulcer differs slightly. In grade 1, medical management comprising of muscle stabilizer with topical steroids forms the mainstay of therapy. Bandage contact lenses may or may not be required for healing of these lesions. Grade 2 and grade 3 would require medical management. However, the debris in the base of the ulcer has to be debrided, and this may or may not be supplemented with a bandage contact lens or an amniotic membrane transplant. In recalcitrant cases, we may use supratarsal steroid injections. So the therapy involves the use of a muscle stabilizer. We prefer 4% sodium chromoglycate, which is used twice daily. This is supplemented with topical steroids, high dose or low potent topical steroids as the case may be, which are used in a short pulse dose for about 3 weeks, which is the time taken for the muscle stabilizer to kick into action. For steroid responders, or for the once the disease is in remission, we would use immunomodulators like cyclosporin or tacrolimus. In recalcitrant cases, we would use supratarsal steroid injections. Grade 2 and grade 3 ulcers will require debridement with the insertion of a bandage contact lens or the placement of an amniotic membrane transplant. So the supratarsal steroid injection is given in the upper border of the tarsus where there's a potential space. So the upper eyelid is everted with a little minimal pressure backwards that causes the conjunctiva at the upper border of the tarsus to bulge forward, and into the space above the upper border of the tarsus with the help of a 26 gauge needle, we inject 0.5 ml of triamcinolone acetonide into this space. So this is believed to be very effective and has shown good results. But how does a therapy work for the different grades of shield ulcer? This was a publication that came from the LVP in 2013, where it was noted that 94% of the cases healed with medical management in grade 1 shield ulcers, 88% in grade 2, and only 17% in grade 3. But those who had undergone a debridement or an amniotic membrane transplant had a much higher resolution. The time to resolution was not different between the different groups. The other modalities that have been tried are amniotic membrane graft for refractory GPCs in a series of 13 eyes, of which 5 patients had shield ulcers, where a double-layer amniotic membrane was placed on the tarsus, and it was noted that the lesions resolved in 2 weeks without recurrences over a duration of 9 to 22 months. Geeta Iyer's group has looked at mucous membrane grafts for giant papillary conjunctivitis. They had a series of 11 eyes with refractory GPCs, all of whom had recurrent shield ulcers, and they placed a thinned out full thickness MMG on the upper tarsus. And in their follow-up of 8 months to 8 years, they noted there were no recurrences of the shield ulcers with very minimal recurrence of the giant papillae at the edge of the mucous membrane graft. So in summary, isolated limbal VKC and shield ulcer are not as common as the palpable and the mixed forms of the disease. The mainstay of therapy for limbal VKC would be to use muscle stabilizers and or topical steroids with immunomodulators. The topical steroids, when used, will be a high-dose topical steroid with a short duration for the exacerbations. Shield ulcer requires a debridement, particularly in grade 2 and grade 3 shield ulcers, with or without a supplement of a bandage contact lens and amniotic membrane. And other modalities of treatment for refractory cases like an amniotic membrane transplant and mucous membrane graft are promising. Thank you very much for your patient hearing.
Thank you for the presentation. I'm just going to answer the discussion that Ken asked just now. So in Singapore, we do see a late onset VKC, like an adult onset VKC. And I actually find that they tend to have more like papillae rather than the cornea complications. I was just wondering whether it was the same in India. Like they don't get so much shield ulcers, you know, they get the huge papillae.
Yeah, so that was our observation too. But then we did have a slightly higher number of patients who had keratoconus in our group because of the eye rubbing over a long duration of time, particularly in the group which had which started young and then persisted beyond puberty.
Do you also tend to find that they are quite chronic? That means they don't get the corneal complications, but it's just a very chronic, and then they are the ones you watch out for glaucoma and things like that.
Yeah, that's right. So it's very difficult to bring them under control. But fortunately, with the immunomodulators, cyclosporin, tacrolimus, we have been able to get these patients into remission. But I think there's something that triggers it, and then they develop these exacerbations. So we've noticed that in summer, they tend to have exacerbations, and then getting it down, back under control is very challenging. So, but yeah, we have had good experience with these immunomodulators.
And for us, because it's there the whole year round, so we've had to use quite a lot of these immunomodulators. Is it like that, or do you have like a seasonal sort of peak?
I agree.
It's perennial, yeah.
So for children who have it, we'll end up using immunomodulators throughout the year. In fact, we've had patients on it for a couple of years altogether. Kind of worrisome for the parents, but we find it very safe, and that's why we've been using it for so long. But if they do stop the medications, then there's a tendency for exacerbations once again. So we keep them on it long term.
Would any of the rest of the panel like to comment on the late onset VKC?
So I have a couple of questions about the talks that we just heard that I don't want to let go, because we're drilling down, and we're going to continue to drill down pretty granular and get and with the specialists that we have. But there's some basic questions I want to ask them. And we heard the discussion of flipping the lid. Sometimes these kids are young and they're uncomfortable. I'm just wondering if we have any basic tips on how to flip a lid.
So I think one of the things is that I don't use an instrument. I just use my fingers, and I find it's easier. You can judge the amount of tension and pulling a lot easier. I find with using a Q-tip or another instrument, it can be more painful for the children, and especially early on, they don't necessarily trust you. And so once you've achieved that trust, and they know they're doing it all the time, that helps. There are some children who will never let you flip their lid, and their lid is really thick because of the skin and because of all the giant papillae. So what I'll do with them is I'll actually take them away from the slit lamp. I'll have them tilt their head back, look down, and pull the lid back as far as I can, just without everting it. Usually using a light, you can actually look underneath and see if there's anything significant. It's not as good, but it tells you if there's very large GPC there in it. It's a lot less scary for them. They don't have to have that feeling of the lid everting. So that's what I've done.
Fabulous tips. Merle, do you have anything to add for flipping a lid?
No, just the same.
Then the other question I had for both of our panelists was that we've heard about VKC, but we're talking to a global audience. Is VKC more common and different in different parts of the world? Sawe mentioned some of the older VKC patients that she's seen, and is it geography and environmental exposure, or are there genetic differences that we're seeing in different parts of the world?
I mean, I think that's really hard to say, because most of the people on this call are at big centers where they'll see a lot of GPC. And what I found is, just looking through the literature and incidence, it varies so tremendously between areas. So there's obviously some genetic component. In Toronto, we have a lot of different ethnicities. And I have to say, I see GPC in every ethnicity that's here. It's really hard to actually say that it's more common, but maybe other panelists have a different experience than me.
I just wanted to say something about terminologies. Asim, I know exactly what you mean when you say GPC, but there are going to be people who are optometrists listening to this, and they're going to think of GPC as the contact lens related disease. And I tend to call this cobblestoning or cobblestone, so that there's no confusion, because they're a different disease, as you know. But I understand what you mean when you refer to it as GPC, but sort of in terms of precedent, GPC is considered to be a contact lens related issue. So I just wonder if we could sort of keep it consistent and talk about cobblestones. I don't know how the other people feel, but I don't want any confusion. This is a different, that's a different disease. But I would agree with you. There's no doubt that sun exposure, Merle said that in the summer, they see these sort of flares. Sun exposure has a role. And we know that if you look at the epidemiology, that the closer you get to the equator, the increased incidence of this disease. Now, whether it's genetic or whether it's just purely sun exposure, I don't know. And I'd be interested to know what the other experts feel and think.
Well, I agree, Ken, because I really think that GPC should be reserved just for the form with contact lens dominance. So I think really giant papilla will be all right, or cobblestone is good. For the genetic, it's very complicated because it's an allergic disease for sure. So allergy is genetic, it's multifactorial, it's not direct genetic. And so I can't imagine there is no genetic in between for this VKC. But definitely when you look at all the world, there is different forms in different geography localization. And we work with COA for Asia, and even in Asia, there is different forms, probably because the climate is different. So for sure, in France, we have more giant papilla than limbal forms. But if you go more in the south, there is more limbal forms. So this disease is really very interesting because it's multiple forms all around the world. It's the same disease for sure, but probably the environment is very important, as it has been demonstrated in exact studies and other allergic studies. Thank you.
Great. We're going to continue to dive deep onto some of these issues because it's fascinating to hear experts from around the world. Next, we'll hear from Ken Nischel about how this impacts the lives of not only the child, but the family. So Ken's talk is up next.
So you're probably glad, David, that I was muted.
You were rejected somehow, I guess.
I was rejected.
Don't worry, you're not alone, Ken. You were not alone.
Can I just say one thing? Oh, we're starting. Okay. Thank you very much for asking to speak in this webinar about something that I think is really important. That's the quality of life for patients with vernal keratoconjunctivitis. There's very little in the literature about the carers of these patients, but plenty about the patients. So my disclosure of conflict of interest is that I've received honoraria from Santen discussing VKC and therapies for it. So we know about the clinical signs. Here's a child with swollen red eyes. They can have tarsal conjunctival involvement, the limbal involvement with Tranter's dots, and they can also get the shield ulcer. We know about those. And here's a child rubbing their eyes constantly because of the itch that they're getting. So while the clinical objective evaluation of signs and symptoms is commonly used to evaluate VKC severity, this may not reflect the impact of the disease on the patient's health-related quality of life. So what I'd like to do in the next few minutes is talk to you about, this is a paper which I personally think is excellent. Basically there was a development and testing of the quality of life in children with VKC questionnaire, they call it QUIC. They started off with 51 queries, ended up with 16. And if you look here, this is all 42, then they drop it to 30 in bold, and then they have the 16 that they actually asked. And then when you look at those, you can see that itchy eyes, eye burning, ocular redness, really quite high. And also in terms of daily living activity, you've got problems going to the swimming pool, problems practicing sports, problem meeting friends, and problems playing outside. Basically what children do all the time. Look at that again. It's really affecting their daily living activity. However, what the paper showed was that the QUIC questionnaire has two domains, symptoms and daily activities. there was a significant correlation with the clinical objective parameters of VKC severity, indicating that the quick symptom domain is related to disease process. However, for the daily activities domain, the lack of significant correlation to clinical signs was explained by daily life adjustments and the perception of the disease by the children, their parents, or both, and also the severity of the disease at the time of the visit. The parents' perception of the disease also affected how the child coped with the disease. So this paper, again, this was from Columbia. They looked at this questionnaire called KidScreen, and you can see that they have all these questions and domains that they covered. But what was really interesting, which I find fascinating, is that they compared the domains of individuals affected by VKC and found that they were lower than those qualified by children with chronic illnesses, giving very similar results to the population of validation cohort questionnaire that was the cohort that was hospitalized. So VKC is worse in terms of quality of life than all these other chronic illnesses. And that's something that I don't think we really take on board. This was a paper published in 2021. They used the quick survey and they looked at the symptoms domain and the living activity domain again. 70 subjects, 10 female, 60 male, mixed, tarsal mixed ratio of VKC 36 to 34. And the clinical severity as measured by the Bernini scale went from mild, moderate to severe. There was no significant difference concerning the distribution of any patient demographics with tarsal or mixed type. And a significant positive correlation was found between all quick scores and VAS scores. VAS scores are visual analog scales. I'll talk about those in a minute. And no significant correlation was found between quick scores and total science scores, Schirmer's test, or corneal thickness. The presence of active severe VKC was not associated with a worse health-related quality of life. So the visual analog scale, you had subjective symptoms, 4 photophobia, tearing, ocular, mucous ocular secretions, and then the total scores calculated as a sum of VAS scores for this main 4 VKC symptoms. We got a score from 0 to 40. What they basically found was that the quality of life, as measured by the quick questionnaire, significantly worsens as symptoms VAS scores increase. So the more the symptomatic problem, the worse the quality of life. VKC form did not have significant effects on quick scores, suggesting that the VAS and quick scores are highly associated independently of the VKC form, and the presence of active severe VKC was not associated with worse health-related quality of life. And this suggests that the sole evaluation of the characteristics of VKC clinically may not be enough to predict a decline in the quality of life, and that's really very important. This is the Bernini scale used that I discussed, grade 1, 2, 3, and 4. And so in conclusion, I was going to say that the quick questionnaire may be used in clinical trial settings to assess changes in quality of life in children with VKC, which may help us better tailor the treatment. And interestingly, the quick questionnaire was used in the vector study to evaluate the effects of treatment with cyclosporin A cationic emulsion in patients with severe VKC. Both the quick questionnaire domains improved after treatment with high-dose cyclosporin A cationic emulsion. So on that note, thank you so much for listening, and I'm delighted to have been part of this webinar today.
Ken, thanks so much for sharing your expertise. I'm going to do it again. I have to add this. I have VKC, and the quality of life. I remember so clearly my dad grabbing my hands and us battling over me wanting to rub my eyes. And to this day, I can't swim in a chlorinated pool without wearing goggles because my eyes get irritated by it. My mom grabbing me and pulling me back in the car because as I got out of the car to go to school, they were cutting the grass right next to me, and wham, my face exploded. These are real, and they really do affect the child and the family on a daily basis, and changes how you live your life. So thank you for pointing out how important this all is. It's dramatic. We'll talk a little bit more about it after Sunita's talk, and as we start getting towards treatment and why it's so important to get to early treatment. And what the problems are with some of the treatments that are available now.
At the outset, I would like to thank WSPOS for giving me the opportunity. Steroid-induced glaucoma is an important cause of avoidable blindness in patients with VKC. Steroids are required to control the acute episodes of allergy and inflammation, leading to higher propensity for disease and treatment-related complications. They can be used up to 85% of patients with VKC. However, it is seen that there is often an indiscriminate and unmonitored use of topical steroids. The incidence of steroid-induced glaucoma in patients with VKC is 2 to 7%. The magnitude of problem is quite substantial. Since it affects the young individuals, it may lead to many blind years with a significant effect on patients' quality of life. As seen clinically, steroids are often prescribed by pharmacy, quacks, or general practitioners, and especially more common in rural settings. Easy over-the-counter availability, low cost of topical steroids, and dramatic response to steroid therapy leads to the unmonitored and excessive use of steroid. It's a major cause of severe visual impairment among children, and study has shown that a third of children presenting with steroid-induced glaucoma at a tertiary care center were bilaterally blind at presentation. And in another study, more than a third were bilaterally blind. So the clinician has to be vigilant to corticosteroid response, which can lead to irreversible loss of vision. So we have high potency, moderate potency, and weak potency steroids, which we use to treat clinically the VKC. Ong et al. Described several risk factors which were related to the treatment as well. So the mixed type of VKC, significant limbal neovascularization, corneal involvement, and high recurrence per year, as well as longer duration of corticosteroid use of high potency steroids, and topical application of steroids are the major risk factors. Amne and Becker suggested 3 categories. 4 to 6% of the population were high responders for steroids, and 2/3 of the population are said to be non-responders. Children are more prone to steroid responsiveness compared to adults, and children with VKC have even higher steroid response rate. Now coming to pathophysiology, decreased outflow or alteration of the metabolism of mucopolysaccharides leads to accumulation of mucopolysaccharides in tubercular meshes. And this accumulation can cause retention of water, which is termed as biological edema, causing narrowing of the trabecular spaces. Also, steroid-induced inhibition of phagocytosis could result in accumulation of channel debris and decreased facility of outflow, contributing to glaucoma. Now, coming to the management, first and foremost is to stop steroid and substitute the steroids with the non-steroidal safer options. Generally, the chronic steroid response resolves in 1 to 4 weeks. Now we have better drugs, the immunomodulators such as cyclosporin and tacrolimus, which inhibit T cells and decrease the inflammatory cytokines. And they're used as steroid-sparing agents to prevent recurrences. And studies have shown that if they're used for a prolonged period of time, they can decrease the need for steroid and severity of the disease. As far as anti-glaucoma medications are concerned, beta blockers and CAIs are considered the safer options because of better tolerability. Brimonidine and PG analogs may not be tolerated so well because of the side effects. However, 16 to 62% of the patients may require surgical intervention, and the risk factors for surgical intervention include prolonged duration of topical steroid use and greater increase in intraocular pressure from baseline. Also, the severity of glaucoma in children correlates with the greater need for surgery to control their IOP in VKC. A study by Sirota et al. Shows that more than a third of children with VKC and steroid-induced glaucoma required filtration surgery in contrast to medical control of glaucoma in more than 90% of patients with VKC due to other causes. So these children are more predisposed. In Singapore study, however, only 16% of the patients required surgery. And in another study from rural setup, 62% of the patients required surgery. That means the patients from rural setup had more severe disease and they present late. Trabeculectomy remains an effective treatment for glaucoma in those patients who are refractory to medical therapy. However, the success of trabeculectomy may not be so good, and it is attributed to chronic inflammation of conjunctiva in these eyes, which predispose them to the long-term failure of trap. Mitomycin C had a substantial effect on the clinical course of disease when applied on the sclera, subconjunctivally or locally. And in most of these cases, the need for topical steroids and the frequency of steroids reduced post-operatively. So post-operative, there is a general improvement in ocular surface and reduced corneal epithelopathy as noticed in various studies. Since mitomycin C inhibited fibroblasts on the ocular surface, it sufficiently reduces the signs and symptoms of VKC. So to summarize, inadvertent use of steroids in children causes enormous visual disability. So the awareness and use of steroids and medication can prevent these serious complications. And when steroids are indicated, prescribing a low-dose steroid and closely monitoring of elevated IOP could result or prevent blindness in these young children. Also, if diagnosed and treated early, most of the cases can be treated successfully by topical medications. So as ophthalmologists, it's our responsibility to educate the patient about the sight-threatening complications of steroids. And also, we should educate the patients and parents on the risk of unmonitored use of steroid medications. General ophthalmologists should be educated on blinding side effects of steroid use and importance of monitoring when steroids are prescribed. Measures need to be taken collectively by patients, ophthalmologists, and government to prevent steroid misuse. Thank you very much for your kind attention.
Thank you, Sunita, for that talk. I was just wondering, Sunita, you have a huge pool of patients, and could you share with us your experience on what are the characteristics of these steroid-induced glaucoma, and what were the risk factors, and what was the treatment outcomes and all that in your huge pool?
Yeah, I think it's a very important question. Actually, I would just like to talk about a study which was done in a consortium where we have 4 centers, and 2 of the centers, they cater to the rural population. So I would like to stress here that in India, actually the use of steroids is very indiscriminate, and even without prescription, I think the people can get the steroids over the counter. And especially in rural India, they do not have that much approach to the eye care facility, and they're more likely to get their steroids or medicines from the pharmacy or general practitioners. And since the steroids have dramatic response, they give immediate relief from symptoms. As we have seen that most of these patients and these children are very symptomatic with itching and redness, and they keep rubbing their eyes, and if steroids are used, then there's immediate improvement in the symptoms. And that is the reason the patients who have shown to the ophthalmologist or general practitioner once, later when they develop the symptoms, they start using the steroids on their own. And that is how they get into the habit of using the steroids every time and getting, improved. And over a period of time, because of the prolonged use of steroids, they get the raised intraocular pressure. And so I think that is the reason in India, the steroid-induced glaucoma is very prevalent, and especially in rural setting. And I have noticed, especially like the type of glaucoma which we are getting are quite refractory to the medical treatment, and almost 35 to 45% of the patients require surgery. So they are so refractory. And since we were talking about this severe disease, what I have noticed in my experience is that most of the patients in whom I have prescribed, I have done surgery, but not so severe. They didn't have very extensive mixed type of disease or tarsal, cobblestone appearance, maybe because they use steroids very frequently that arrested the other complications like corneal complications, but they developed very intractable glaucoma. So I think that is my experience of treating patients of steroids. And if you allow, I can just apart from, I have talked about trabeculectomy, but now we have MIGS, and I have seen, I have done trabecular ablation in these patients. Recently, one patient, a child who was 14-year-old, came to me. He developed retinitis after viral infection, and he was treated with intraocular steroids. Both eyes, posterior subtenon steroids were given, and he developed intractable high intraocular pressure. Although the optic nerve was not so bad, and he came with 45, 50 pressures in both the eyes of 3 to 4 weeks duration. And I did both eyes trabeculotomy, ab internal trabeculotomy with Cahoog dual blade, and the pressure came down. And it's quite logical that the disease has not yet extended to the collector channels and the trabecular. If you have ablated trabecular meshwork, or if you have removed the diseased trabecular meshwork, again the filtration has started and the pressures have come down. So if you treat early, I think the prognosis is really good. So that is my take.
Can I say something? I wanted to just congratulate Asim and Merle. Firstly, Sunita, your talk was fantastic, but Asim and Merle showed some amazing pictures which showed very clearly that while steroid rescue is helpful in the short term, and we've just talked about the side effects of steroid, that there should be another treatment. I mean, if ever there was a picture, Merle, the picture you showed of the limbal involvement followed by a stem cell failure, I mean, if there was ever evidence that we need to change the way we approach this disease, those pictures that you and Asim showed are the evidence in the court of clinical paradigm shift. Because the steroids may give you rescue, but the damage is already done. And I think that's where the calcineurin inhibitors make such a big difference, and the newer ones that we're going to talk about, they completely change the course of the disease. So I want to just put out, that I learned a lot looking at the quality of life papers, which I don't think we do enough of. And it showed that it doesn't matter about the degree of the disease. The quality of life is independent of that, depending on how parents respond. Now, David's father clearly showed him to suck it up and get on with life, right? Because that's why he is where he is. But there are parents who we've all seen them. They're kind of like in a heap, just like the child is, and the child has got their eyes closed with a wet cloth on their eyes in the clinic. So, what do you guys think? What does everybody think? Isn't there time that we changed our approach to this disease, given everything that we've just heard?
Yes, for sure. That's true, because I think we really need to think that there is steroid-sparing eye drops, and that's the point. And it is very important, because the earlier you can do it, the earlier you have better results. And that's why we have probably a very severe disease with limbal stem cells deficiency, because the disease just is lasting a long time. So I agree with you. We have to change. Steroid is very good for short treatment, but not recurrence, and not for over the counter.
So one question that was brought up on YouTube that I want to make sure that we touch on is that there is the possibility now of doing intracanalicular steroid inserts. Now that's giving steroid, chronically for this essentially. Ken, you feel very strongly about avoiding the steroid. Is that going in the wrong direction?
Look, in my opinion, it is. Why would you want to use a steroid? I mean, you can get a steroid response as soon as 72 hours. I've seen steroid responses at 72 hours. And why would you want to do that? I mean, if there are alternatives. Now, there are parts of the world where maybe there isn't access to the steroid-sparing drops. And what we should do as a society and as pediatric ophthalmologists around the world is put pressure so that there's access to steroid-sparing drops. Asim, Merle, Annegret?
I have a comment. I mean, I think this is like the analogy of uveitis treatment. Uveitis treatment was steroids, oral steroids, topical steroids. And now, 20 years, I mean, this is before even I was training, we've moved on to other things. And when we've looked at the data, people do much better now with uveitis. The paradigm is not to put people on long-term steroids. And we're seeing the results. There's much less glaucoma, much less cataract. And I think this is where this disease should go. We're just lucky we have drops. We don't have to use systemic agents here. And I think that's a really strong, I think when you're looking at VKC treatment down the road, there'll be hopefully a lot less talks about steroid-induced complications of VKC.
Annegret?
Yeah, I'd like to make 2 comments, please. One about accessibility or access to the calcineurin inhibitors. There is a problem with the price tag. So it's not just that they are not licensed in all countries, but even in countries where they are licensed, there is always an economic argument that steroids would be a lot cheaper. And if it's a disease that flares up sometimes, wouldn't it be a lot cheaper to give the kids intervals of steroids? And I think that is something that we need to resist where we can afford to. But it is definitely an elephant in the room. And the second thing I wanted to say is that I completely endorse what Ken said about quality of life. And there I would take the management guidance further. So we now trust parents and children to say how many times a day they need to apply these expensive drops. So they all know that when things are bad, they must use them 4 times a day. So that's the spring and summer months. And that there might be a good point if they have a longer history of VKC to stay on the drops, but at a reduced frequency of maybe twice daily over the fall and winter months. And then when they know the flare-up is starting, because they can feel it, then to go straight back up to 4 times a day. And even then, so in our experience, that does seem to reduce the severity of flare-ups in the second or whatever subsequent season. But there are still some children who are not fully controlled with the cyclosporin A and the dual-acting mast cell inhibitors and antihistamines. But I do strongly believe that because ophthalmology appointments are so rare and access to us is also very limited, we need to be better at educating families and trust families to do the right thing as well. Thank you.
I think that's a perfect lead into your talk. And so if we can cue that up, we'll have our final talk and then we'll have an ongoing panel discussion. And it looks like we may go a few minutes over because everyone's pretty passionate about this.
Hello, thank you for inviting me to contribute a brief talk on management options in Vernal Keratoconjunctivitis or VKC. My name is Annegret Dahlmann-Noor and I'm a consultant in pediatric ophthalmology at Moorfields Eye Hospital in London. I would like to structure this talk based on a paper that we recently published in WSPOS, which was a consensus exercise between different centres and different multidisciplinary specialists working across the UK. And we agreed that it would be most appropriate to adopt a stepwise approach, depending on the severity of VKC at presentation, whether signs and symptoms are mild, moderate, or severe. In mild VKC, the typical presentation is that a child is brought in with eye rubbing, red eyes, watery eyes. Often they have not had a diagnosis of VKC before, and on slit lamp assessment there are no sight-threatening signs. In terms of treatment, we would recommend simple topical dual-acting agents, but we also recommend behavioral adaptation and modification. So we advise the parents to check the pollen count or the UV index in weather apps on their phone before letting the child outside, and that it is maybe wiser to stay indoors if the pollen count and UV index are high. We also recommend that they get the child a hat or a cap with a shield to protect the eyes a bit from the direct light, and to wear wrap-around sunglasses to reduce the exposure to pollen. At this level of inflammation, you want to target the histamine in the tear film and the mast cells, which release the histamine. And we have dual-acting agents, which I prefer for children because they only need to be applied twice daily, so that's pretty easy for the family. And we can choose between olopatadine and ketotifen, with the latter having the slight advantage of coming preservative-free. If they are already on oral antihistamines, we recommend that they can continue, but advise the parents that the oral antihistamine alone will not reach a level in the conjunctiva sufficient to dampen the inflammation. They can also try ocular lubricants, but I would only advise that if they are only on twice daily proper medication and are just looking for something to use in between, and then the lubricant will dilute the cytokines at least. But as soon as you need to escalate the treatment, I would stop the ocular lubricants. In moderate VKC, you start to see corneal epithelial involvement. There's often a limbitis, so this typical Horner Truntus dot appearance of these whitish beads around the circumference of the limbus, and they have larger tarsal conjunctival cobblestones. So it's always worthwhile everting the upper eyelid and checking the tarsal conjunctiva there if you feel confident and competent to do so in a child. They develop a punctate keratopathy, which you can see with fluorescein staining, and not only inferiorly, often in the superior cornea, so in direct contact with the large cobblestones under the upper lid. And often there is a whitish or grayish mucoid discharge, stringy discharge that they literally pull away from the eye, and parents often bring in photos showing you this. Or the presentation can be in a child who has had VKC the year before, stopped the treatment over the winter, and is then presenting with a flare-up. Here you want to escalate the treatment. You want to either shut it down completely or go higher up in the inflammatory cascade and target the T2 lymphocytes specifically. So you continue the dual acting, but you also want to consider a short course of topical corticosteroids, lower penetrance if possible and available, such as loteprednol or fluorometholone or even dexamethasone, preservative-free if possible. Consider starting a calcineurin inhibitor or restarting it if this is the new season. Commercially available now is cyclosporin A 1 milligram per milliliter under the brand name of Vercasia and licensed for use in children with VKC. If there is also atopic dermatitis, so the lid skin being red and inflamed and very dry, or the inflammation on the ocular surface is refractory to cyclosporin A, consider tacrolimus skin ointment, which comes in 2 different concentrations. Although not licensed for use on the ocular surface, it is well tolerated and works well. In severe VKC, we're heading into the territory of the shield ulcer, often with corneal vascularization and often with very disabling photophobia. There's often a lack of response to the treatment that you have been giving for several weeks already, or there can be repeated flare-ups despite good adherence with treatment. So again, you can distinguish different stages and tailor your treatment approach. So fine early punctate staining, early keratopathy you manage with a topical treatment already discussed. If there is stage 1 of severe VKC with a coarse epitheliopathy and the adherent mucus, consider maximum topical treatment, so a stronger steroid given more frequently, introduce cyclosporin A and maintain the dual-acting agents. Also throw in the acetylcysteine, a mucolytic, 10% if possible, otherwise 5%. If it progresses to an epithelial defect, macroerosion, or ulcer with a clear or translucent base with a minimal plaque, consider adding an oral steroid. At Moorfields, we use oral prednisolone 1 milligram per kilogram up to 40 milligram maximum once daily for 3 days, and give a topical antibiotic such as chloramphenicol 0.5%. If you're looking at an established plaque, then in addition to all of this, you need to consider scheduling the child for a procedure, a superficial keratectomy and a subtarsal injection of triamcinolone 20 milligram once control of the inflammation is achieved. And you may wish to combine that with a bandage contact lens or an amniotic membrane graft to promote healing. In addition, if the ulcer has got an infiltrate in the corneal stroma, you may want to use a different topical antibiotic, such as a topical quinolone instead of the chloramphenicol for at least 48 hours before starting a topical corticosteroid or cyclosporin A. So in summary, we would recommend a stepwise approach. Check your signs and symptoms. Decide whether this is mild, moderate, or severe. If mild, only behavioral adaptation and topical antihistamines and mast cell stabilizers are needed. If it progresses further, use steroids, calcineurin inhibitors. If you're looking at shield ulcers, then you might need to add in the mucolytics if there is mucus, and oral steroids, a short pulse course of prednisolone, and plan surgery. Thank you very much for your interest today.
Annegret, thank you so much. That was very powerful. And I think that all of us need to remember that first step, right? Avoidance of the allergen. We can never forget that. And for one last time, I am going to make this plea that all the people that we're talking about are real people. That's my eye. You can see the scars from the horn of Trantis dot and the small shield, superficial, superior limbal ulcer that I had. That had this gone much further, I wouldn't be an ophthalmologist. So this stuff is real, and it makes a big difference in people's lives. What I was taken by, Annegret, is the fact that you were talking about when people get to you, the stage of the disease. How do we stop the disease from progressing when it's mild from turning into worse? It sounds like we can avoid steroid use, procedures, injections, if we can prevent or abort the disease process. And it sounds like you're comfortable using cyclosporin. Which one? There's several, and does it matter the strength and or the carrier that it's in?
So Moorfields, before my time, have used different compounded preparations that were made in the Moorfields pharmacy. But for us, the commercial preparation has really been the game changer. And in the UK, the 4 times daily application of cyclosporin cationic emulsion 1 milligram per milliliter or 0.1% under the brand name of Vercasia is licensed for use in children. So it is dosed, the box contains enough to use it 4 times a day for a month. But before that, 3 years earlier, there was a marketing authorization for the same formulation under the name of Icavis for severe dry eye related keratitis in adults, used to be used twice daily. So that's got a different brand name, Icavis, but it's the same formulation. So we're using both in children, and usually, because this is a publicly funded healthcare system, the commissioning bodies are also very eager that we switch from high frequency Vercasia to low frequency Icavis at some stage, if possible, because it's cheaper. But for us, the game-changing aspect was that because we can now initiate the prescription, but the family doctor can continue it, the burden of treatment isn't on the hospital, and it's not on the family either, in the sense that they don't need to come back to the hospital every month or two just to pick up a repeat prescription. So suddenly... And so
when we talk about cost, you just brought up the cost, the burden to the family, of coming back and forth to the doctor. There's also the cost to the healthcare system of having to do injections or treat. And then there's the cost to the patient who If my disease had gotten worse, I would have diminished vision. I wouldn't be an ophthalmologist. These are enormous costs. And if it ever gets to corneal transplant or other procedures or a trabeculectomy, I mean, those costs dwarf anything that we're talking about.
Couldn't agree more. Absolutely. The problem is that that's a gap in the literature. So there, all of a sudden, you come back to VKC being a rare disease, which I think in none of our practices, VKC is anything like a rare disease, right? But it still comes under the umbrella of rare diseases, and there hasn't been a thorough health economical analysis that would factor in the long-term complications. And yes, we have all seen children who have had 5, 6, 7, 8 episodes of shield ulcers and all the treatments that required. And then, of course, the balance tips completely.
Dominique, is Paris any different than London?
Sorry, I didn't get exactly the question. What did you say?
Does Paris approach this disease any different than London might?
Well, I really think we should go to steroid sparing, but the problem is for sure the cost. But also, when you just look at the cost effectiveness, I agree, because the cost effectiveness of the disease when you go to keratoplasty or trabeculectomy is so high. So this is really important. The alternative also is probably also the hospital preparation, because at least I think in France it's less expensive. At the opposite, I think the cyclosporine A with cationic emulsion is more, it's easier to be, it's a better, it's better good for, I mean, for the children, they feel really better with the cyclosporine with cationic emulsion. But at least we can have also preparation at the hospital. I think we must consider that if there is a problem with financing problem.
Sunita and Merle, I got scared when I heard that steroids are over the counter in some places in India. How important is it for the message to get out there that there's a safer medication that can alter the course of this disease, protect the child with VKC or the adolescent or even the adult from the consequences of steroid use and the consequences of the disease? How important is it to get that message out there?
I think it's very...
Well, Sunita?
Yeah. I think it has to come from government, and there should be regulations from government, and the indiscriminate use, and the pharmacies just dispense the drug over the counter, and the patients do not know the consequences of using the drug. And the government has capped the prices of the high potency steroids, the dexamethasone and betazone. They are much cheaper than the low potency steroids like chloromethanol. So that again, I think facilitates the use of high potency steroids. So I think the use of steroids should be banned unless it is prescribed by the ophthalmologist. I think that regulation should come from government. So it is an effort it should be an effort from the ophthalmologists, the physicians and government to create awareness about the blinding side effects of steroids. I think it should be taken up as a project. And as far as now, the institutes are concerned, the tertiary care institutes, I think we have that awareness campaign. We have we give the child the leaflets, the education, which educates the children and parents about the importance of coming for regular follow-ups. And since this disease, I am a glaucoma specialist. The child first comes to the pediatric ophthalmologist, and then if the corneal complications develops, then the child goes to the cornea specialist. So I think it's a co-management of the disease by the pediatric ophthalmologist, the cornea specialist, and the glaucoma specialist. And every time the comprehensive examination should be done, by the ophthalmologist. Every time the IOP should be measured. So I think it should be taken up as a challenge. I think.
Great. Thank you. And Ken and Asim, in North America, I'm not sure how much we use tacrolimus. What's the role, and what do we all need to know about it?
What? Tacrolimus?
So in the USA, you can't get an eye preparation that's commercially available of tacrolimus. There is something called Protopic that you can put on the skin of the lids when you have atopic keratoconjunctivitis, and sometimes that can sort of leak into the eye and help. But yeah, I mean, I think the Vikasia, which in the United States is licensed for children and adults. I think in Europe and in Canada, it's ages 4 to 18, if I'm not mistaken. But
Yes.
it certainly is, it has changed how we approach it. I mean, cost is an issue. We've started prescribing it, and we're having authorizations and pre-authorizations and physician-to-physician calls with the insurance companies. But I have to say, Santan's been very helpful in helping us, get the drug for the patients who need it. So I think it's definitely going to make a difference. The Vectis study showed how effective it was. But I don't have tacrolimus. I just don't have access to it as an eye ointment. I don't know about Asim in Canada.
Yeah, so we have access to Vikasia, and there is public support for people who can't afford it under the terms and the criteria and the Vectis study. So we have to utilize it appropriately for children with VKC. We still have access to compounded cyclosporin and tacrolimus drops. There are some children who are not fully controlled with Vikasia, and so I do have a few that I will move on to tacrolimus or cyclosporin. I like higher concentrations, like 2%. But I would say, by and large, the 0.1% cationic is my go-to as my first line now, and it's actually pretty well tolerated by most of the children, which is a problem with compounded drops. It's something wasn't really talked about, but burning in higher dose cyclosporin and in tacrolimus can be a huge problem for some children, and they'll rather not take the medication, and that compounds the whole problem.
David, can I just make one other point about shield ulcers? I'm very aggressive. I see a shield ulcer, even with a translucent base, I'm going to take that translucent material away. And the reason why I say that, as a pediatric cornea specialist, every year I see 2 to 3 cases where the shield ulcer has been left with the translucent base. It becomes a plaque, and then it actually just melts through the cornea. These children turn up with a huge anterior chamber inflammatory reaction. They've got a melting cornea. You just don't want to go there. If you see a shield ulcer, even if there's a translucent base, peel that away. Just take them to the OR under mask, peel it away. You've got to get rid of that. I don't know how Merle and Asim and Dominique feel about that.
I agree. I take it off. I agree. I take off and do a amniotic membrane transplant, and it's very easy with some lyophilic membrane. So that's good. And we have access also to tacrolimus in even eye drops or ointment. But you must have in mind that only cyclosporin A with cationic emulsion has the indication, so that's really important. And tacrolimus could be a good option for adding to the treatment if it's not enough. I think we should use those eye drops, and because it's steroid sparing and it's really important for avoiding complication of steroids.
I completely agree with Ken on the Dominique on the shield ulcers. You just can't leave them alone. They never heal. And when I've seen them incompletely treated, which is not very common, they sort of come back, they kind of heap over, you get the blood vessels coming in. The quicker you can get rid of it, the quicker the child feels better and the less chance of problems in the long term.
Okay, thank you everyone for the discussion so far. Can I just ask everyone on the panel for one final comment or take-home message? Maybe we can start with Dominique. Like one.
Yes, sure. Just one, do the right diagnosis and be steroid sparing.
Dr. Asli?
avert every lid.
Okay, and Dr. Fernandez?
I think debridement of shield ulcers, particularly when there's a translucent or a base or a plaque.
Dr. Nishal?
Remember that the studies show that children with VKC have a worse quality of life than some children with chronic diseases like transplants, etc. So be aggressive about the treatment.
Dr. Dubey?
Judicious use of steroids to prevent blinding complications, steroid-induced glaucoma, and more use of non-steroidal anti-inflammatory and anti-allergic drugs.
Dr. Daman?
Use steroids to control acute inflammation quickly to make the child comfortable, and switch to steroid-sparing calcineurin inhibitors as soon as possible.
Thank you so much.
David, just before you start, I just want to say, I think this has been one of the best panels I've ever been involved in for allergic conjunctivitis, for VKC. And I want to thank everybody for, and being a part of it. Thank you. It was amazing. Thank you.
Ken, I want to echo that. And you started to say for allergic disease, but I think that this really is something that we have to put in context and separate out different forms of allergy. It's so easy just to say someone has allergic conjunctivitis without the finesse and understanding and depth that we heard today from the panel. I think it's really important to be able to separate the various different diseases. For the audience, which our panel, you were busy, but we were getting input that the audience truly was worldwide, literally every continent, from all parts of Asia, India, China, Singapore, Australia, New Zealand, Hong Kong, to North America, Canada and United States, Mexico, and Central America, South America, Europe, all parts of Europe, both Western and Eastern Europe. We had guests from Russia who were listening in the Middle East and all throughout Africa. It truly was a global audience today, pointing out how this is a global disease. And for the audience, there were some questions we didn't get to. I think we got to most of them. We will collate those and pass them out to our panel, and the panel will respond to them in writing, and those will be available on the WSPOS website, as they have for all of our webinars. If you have missed any of our webinars, first off, shame on you. But secondly, they are available on YouTube. It's free. And as is membership in the World Society. And these webinars are pretty amazing. We have more coming up that I think you're going to want to see that are just really very special. This was our last one of season 3, but don't worry. After the subspecialty day in Milan in September, which I hope you'll join us at in person, yes, in person, we will have some more webinars coming forward. But for those of you who want to go into depth in any topic, please go to our YouTube page. You'll see incredible webinars. For those of you who train young doctors, either residents or fellows, please send them to those pages. There is so much information that they can learn from specialists from around the world that are just incredible. And then truly, Milan is an international city that we hope to see everyone at. It's the first day of ESCRS that we will have a subspecialty day that'll be pretty incredible, with sessions on cataract, intermittent exotropia, free papers, strabismus syndromes, pediatric cornea, innovations in amblyopia, myopia, a keynote from Paolo Nucci. We'll have videos that we're showing. It will be a day full of worthwhile information, as well as discussions in the hallways and at breakfast, lunch, and dinner with your colleagues that you haven't seen in a while. The podcasts from our meetings are now available as well at wspos.org. They are also fabulous. There are some Journal Club podcasts that are being developed now. There are short posts that are just 1 minute to 2 minute updates from our meetings that we've held, that many of you have attended as well. There are these are our podcasts with journal clubs are also sort of mini celebrity interviews with some of the top specialists in our field. We are thrilled at WSPOS to announce in this year that we have a partnership with the International Agency for the Prevention of Blindness during the year of focus on child eye health. We are so excited that we are now a member and partnering with IAPB to make a difference around the world, which is some of the things that you heard today. Membership in WSPOS is, wait for it, free. So there's no reason not to be a member. It is the largest organization in our field worldwide. There are some nearly 4,000 members now around the world. You get not only reduced article processing from Karger, you get access to the Journal of Binocular Vision and Ocular Motility, one issue a year free. Thank you to them for partnering with us. You get all of our educational videos. We have surgical videos, and you'll stay up to date on everything that we're doing. And most importantly, you have a chance to contribute. Our table of organization is such that we want you to be involved. This is not a top-down organization. It's a bottom-up organization. Most of what we do has been suggested by you. And that's where this all comes from. So speak up. We want to hear from you. If we're doing something that you love, tell us. If we're doing something that we shouldn't be doing, tell us. If you want more of something, tell us. We are here for you. That's why we exist. Please join our Facebook page and group. We want to hear from you. Subscribe to the YouTube channel so you don't miss anything. Write me directly, and I run the listserv for pediatric ophthalmologists internationally. Let me know who you are, where you've trained. We have almost 1,700 pediatric eye specialists from around the world talking every day. And sometimes it's really active with multiple questions and comments coming from, again, all over the world. So it's an exciting way to interact with your fellow specialists. And it's like you're being at a meeting every day, and it comes right to your inbox. Thank you to our audience. Thank you to Santen for their support. Thank you to NTOD for their support. Thank you to our panelists for their expertise, their collegiality, the effort they put in to make sure that this would be special. Thank you to all the WSPOS administrators, Akila, Marie, Danielle, everybody. Thank you. None of this happens without all of you. With that, it's time for everyone in my part of the world to get on with their day, and in some parts of the world to go to sleep and go to bed. So thank you all so much. This is an incredible panel. As Ken said, one of the best panels we've ever had. And your voices mean so much to the children of the world. And that's what I get to do right now. On behalf of all the children in the world, I get to be the one to say thank you to our panel, to our audience for making a difference in their lives. Have a great rest of the day.
Bye-bye.
Okay.
Have a nice day.
Bye.
Everybody.
Bye.
Thanks.